Family mode.
Good afternoon and good morning to you if you are on the West Coast. My name is Dr. Jose Leon, Chief Medical Officer for the National Center for Health and Public Housing. Thank you for attending today's webinar, Oral Health Risk Assessment, Improving Oral Health in Underserved Populations. This webinar is being recorded and the slides, resources, and other materials will be sent to you after the webinar has ended. Also, you can visit our website, www.nchph.org, where you can find the webinar as soon as we finalize this session. Once the webinar has ended, we have a post survey. We will appreciate if you complete the survey. This helps us a lot in improving our webinar sessions. This webinar is done through the National Center for Health and Public Housing, and we are supported by the Health Resources and Services Administration, HRSA. The mission of the National Center for Health and Public Housing is to strengthen the capacity of federally funded public housing primary care health centers and other health center grantees by providing training and a range of technical assistance. I would like to show some UDS data before we get started. This is the number of oral exams and specifically the number of patients and number of visits. These are numbers from public housing primary care grantees, and as you can see these charts, the number of oral exams have increased throughout the years from 2011 to 2015. We can also look at this slide, and this one has information on the number of patients and number of visits looking for oral health prophylaxis. And as you can see, the number of patients and the numbers of visits have also increased. And it's the same pattern when you look at Sealants data and the number of patients and the number of visits since 2011 to 2015. I would like to get started, introduce today's speaker, Dr. Sam Joaquim. Dr. Joaquim is the Chief Dental Officer for Zufall Health Center, a federally qualified health center that provides affordable quality medical and dental care to residents of Morris, Sussex, Hunterdon, Essex, and Warren counties. After graduating from New Jersey Dental School in 2001, Dr. Joaquim obtained a master's degree in dental public health from the University of New Jersey, a School of Public Health. Under Dr. Joaquim's leadership, the dental department won several grant awards and has been selected to participate in a number of Dental Quest Institute Quality Improvement Collaboratives. Dr. Joaquim has enjoyed a long career in public health settings and has been invited to make several presentations at HRSA regional meetings. He is also a frequent guest presenter at the Rutgers School of Public Health. Dr. Joaquim is the recipient of several recognitions and awards, including New Jersey Magazine's Top Dentist, New Jersey Dental Association's Give Kids a Smile Pioneer Award, and the National Organization of States and Rural States Offices of Rural Health, Real Dog Hollywood. Before joining the Zufall Health Center as dental director, Dr. Joaquim worked at the Patterson Community Health Center, where he ran the school-based dental program. Previous to his time in Patterson, Dr. Joaquim was the dental director for UMDNJ's University Dental Center in Newton. During that time, he was also appointed adjunct assistant professor in the Department of Allied Dental Education and clinical instructor in the Department of Community Health. Dr. Joaquim also owns a private dental practice in Chester, New Jersey. He is a strong proponent of properly using preventive measures such as sealants, mouth guards, and fluoride to prevent dental diseases. Without further ado, I'm going to turn the presentation over to Dr. Sam Joaquim. Good afternoon, Dr. Joaquim.
Thank you, Dr. Leon. Good afternoon, everyone, and thank you for having me present today to talk a little bit about oral health risk assessments and using risk assessments to improve oral health for our underserved populations. Before we start, just a little bit about our center. We are a federally qualified health center in North Jersey, with approximately 100,000 visits last year, serving 30,000 patients in Sussex, Warren, Huntington, Essex, and Somerset counties in New Jersey. And we are a nationally recognized patient-centered medical home by the National Center for Quality Assurance. Our work around Caries risk assessment started a while ago. We used to do Caries risk assessments as of 2009. However, we just recorded the patient's Caries risk in the chart without really communicating it with the patient. It wasn't until 2013 when we joined DentaQuest Institute's Early Childhood Caries Collaborative, and then subsequently the Dental Caries Management Collaborative, that we started to use risk assessment as a tool to communicate with the patient, discuss the risk, their risk factors with them, and giving them self-management goals to improve their oral health status. We've partnered with our medical providers who over the past few years have begun to do risk assessments as well and provide varnish to patients seen in medical. We've also partnered with community organizations, and the Head Start nurses have become strong allies in providing Caries risk assessment off-site to children seen at Head Start before we even see them at the center. So we get a chance to know who the high-risk children are kind of before we see them at our center. We've also expanded the use of Caries risk assessment to some of our other populations. You know, we started with children, and we've expanded it to other populations, including our Ryan White patients, and I'll be able to show you that tool in one of the slides as well. And we've partnered with the New Jersey Academy of Pediatrics to increase our outreach to other providers, including pediatricians throughout our area. We have, you know, we definitely believe in doing the risk assessments. It's something that everybody could do. It's a good way to identify patients that are at high risk, and then subsequently provide them with more aggressive care, follow-up interventions, including fluoride varnish application. Our high-risk children we try to see on a regular basis every 3 months and provide them with fluoride varnish. We try to utilize our mobile van. We have a medical mobile van and a dental van that we send out to Head Start to provide fluoride varnish on a regular basis, and we have seen over the past 3 years a significant decrease in caries rates in those children that we follow closely and monitor. The Head Start nursing director reported seeing a 20% decrease in caries rates over the past 3 years, and we're very encouraged by those results. Also, the children that are seen in the center that we treat based on their risk level have had a 15% decrease in their caries rate. So the learning objectives for today will be to review 10 key concepts concerning dental caries and oral health, discuss some of the recommendations from the AAP and ADA for practitioners, and share some tips on tools for implementing risk assessments at your center. So just a little bit about prevalence to begin with. Although largely preventable, dental caries remains the most common chronic childhood disease for children aged 5 to 17. It's 5 times more common than asthma, and between 29 and 59% of adults over the age of 50 experience caries. While in recent decades the United States has experienced an overall decrease in tooth decay, we continue to have a disparity in the distribution of the disease. So 25% of the children have 80% of the disease, and poor children suffer twice as many dental problems as their affluent peers. Fewer than 1 in 5 Medicaid-covered children receive a preventive dental service during the year, so it is a challenge for community health centers, for us to make sure we reach out to them and bring them in, and also find alternative ways to reach those children. And poor children have 12 times more restricted activity days because of dental illnesses than children from higher income families. And high caries experience is associated with low socioeconomic income, low health literacy, parental education levels, ethnic minorities, and recent immigrants. Because dental caries is preventable, it is important for primary care providers, dentists, and community partners in underserved areas to work together to address the challenge. So what is dental caries? A good definition that we like to use is that dental caries is an infectious, transmittable disease that is modified by dietary carbohydrates and critically regulated by saliva. So caries is a disease. We want to move towards thinking of caries process as a disease and less of cavities, because cavities are basically the consequence of the disease. And when we, start treating the problem as a disease, realize that it's highly preventable, and it is something that we could work on together to address. Medical providers typically manage disease. They know how to manage disease. If you suffer from diabetes, the first impulse is not to automatically, take off your foot. In dentistry, we go the extra mile to find the cavities and drill the teeth. Historically, we've been very aggressive in drilling teeth, but with the new thinking of caries management, we realized that we could, prevent decay, reverse initial decay, and we want to move more towards working together to manage the disease process and reverse it whenever possible. So caries is an infection. It is caused by largely strep mutant and lactobacilli. And the interesting thing about this bacteria is that they are facultative anaerobes, so they switch over to fermentation in the absence of oxygen. They synthesize an insoluble adhesive, an extracellular polysaccharide that sticks the plaque together from sucrose. So when you're exposed to the right substrate, they ferment it and produce these glucans. They are relatively more acid tolerant. So whereas the other bacteria may not be, they could produce acid and survive in that acidic environment, and they could produce that lactic acid from sugar very rapidly. Normally, these bacteria are less than 1% of the oral flora. However, with time, if this bacteria is not removed, if not being brushed and removed away from the tooth, then it becomes more prevalent. Another key concept to consider is caries transmission. So caries is a transmittable disease. So after the initial attachment and colonization of the bacteria, goes through a phase of growth and proliferation, and then eventually maturation and detachment. And the primary mode of transmission is vertical transmission from the parent or caregiver to the child. So the bacteria is transmitted via saliva, and then once the teeth erupt, the bacteria colonize the teeth and could lead to decay. Horizontal transmission from child to child is becoming more common, seems to be more common than initially thought. However, the main mode of transmission, as I mentioned, is vertical transmission. The tooth is made up largely of calcium, phosphate, oxygen, and hydrogen held together in a hydroxyapatite crystal. Once that molecules exposed to acid produced by the bacteria. Then the bonds holding the calcium and phosphate together break down, and we have demineralization of the tooth structure. So in the presence of an acidic environment, the tooth demineralizes, and we end up with, after a period of time, we end up with decay. So initially, as you can see on the right side of the screen, this is a cross-section of the tooth. As the calcium and phosphate seeps out of the tooth, we see a white outer layer. The tooth looks like it has a white spot lesion. Then after the demineralization, normally the saliva comes in, remineralizes the tooth, and it's basically a balancing act. The way we describe it to our patients, especially children, we use the Decay Equation. So basically it's substrate, carbohydrate, or sugar, plus bacteria from plaque produces acid, and the acid plus the tooth causes cavities. Dietary carbohydrates are important in the process, so that they supply the substrate, and so diet is very important. Higher, fermentable carbohydrates are more harmful, whereas other foods like milk, cheese, fruits, vegetables, and nuts are less harmful, have more even of a protective effect. There's been some evidence that increased protein in the diet may increase saliva pH, and amino acids cause the oral bacteria to produce amino acids in urea, and thereby increase plaque pH. Again, it's not just the food, but also the drinks. A lot of patients drink high sugar beverages, which also increases their risk for caries. So in addition to having high sugar diet, drinking high sugar drinks also increases your risk. Some drinks also are acidic, so you don't even have to wait for the bacteria to ferment the substrate and produce acid. You could just go straight to an acidic environment by introducing these acidic drinks in your mouth, and at a pH that is 5.5 or below, the tooth begins to demineralize. The way decay happens is once you introduce substrate, bacteria ferments it and results in an acidic oral environment. It takes about 20 minutes for the saliva to come in and buffer the acidic effect in the mouth, the acidic environment. If you introduce another substrate 20 minutes afterwards, it's going to drop the pH, and if the pH stays below the critical 5.5, then you end up with a net demineralization that causes tooth decay. So the next concept that's very important is saliva's critical role. So saliva is a healing fluid. It contains the calcium and phosphate, the minerals that the tooth needs to remineralize itself. The bacteria will remove plaque acid and wash away the bacteria. Also, like I mentioned, it improves remineralization by increasing bioavailable calcium and phosphate. So at night, the saliva is greatly reduced. So that's why we encourage patients to brush and floss thoroughly before they go to sleep, because there's going to be less saliva remineralizing the tooth and protecting the teeth. So the Caries Balance, basically, caries is a dynamic process, and it is reversible up to a specific point. And when risk factors prevail, we end up with disease and caries. When protective factors like saliva, fluoride, and antibacterials and sealants prevail, then we don't end up with disease. So it's important to note that we could inhibit the caries process by inhibiting biofilm acid production with fluoride and other agents, avoiding in-between meal snacking, stimulating saliva flow after meals, and blocking the substrate with sealants and maintaining pH above neutrality. So again, this picture shows the initial white spot lesions on the top left. After this patient has been treated with fluoride and improved home care, that white spot lesion can be reversed and mineralized. Left unchecked, the decay could progress into a larger cavity, which becomes more difficult to treat and harder to reverse and manage. Another important thing to consider with oral health is action of fluoride. So fluoride is very important as an antibacterial, and it's important for the mineralization of the tooth. It inhibits the mineralization of early caries lesions as well, and it inhibits the glycolysis process by which the bacteria metabolizes fermentable carbohydrate. Pre-eruptively, there's some fluoride benefit because it gets incorporated into the tooth and forms fluoroapatite crystals, which are more resistant to acid attack. They will demineralize at a pH of 4.5 instead of 5.5. But the main beneficial effect of fluoride is through its post-eruptive action. So topical fluoride inhibits bacterial enzymes. It combines with hydrogen, enters the bacterial cell wall, and once inside, it disrupts the bacterial metabolic processes. Let's see. So effective community strategies of using fluoride involve using fluoride in water. That remains the most effective way of preventing caries. Recently, the Department of Health and Human Services recommended decreasing the level of fluoride in the water from 1 milligram per liter to 0.7 milligrams per liter, and to avoid any risks of fluorosis. The next best thing would be using toothpaste at a higher concentration. Again, toothpaste, fluoride in toothpaste is bactericidal. In the absence of water fluoridation, fluoride rinse programs, as the school-based rinse programs, are very effective in controlling caries, and then also professionally applied fluorides like varnish are very effective in producing lower caries rates. It is important to know how much fluoride is in your water. The CDC website has a link to My Water's Fluoride, where clinicians and patients can go in to find out how much water is in their, how much fluoride is in their water. For those states that do not participate, they could check out their water quality report, which is typically sent to them by July 1st of each year. The Safe Drinking Water Act of 1974, which was amended in 1996, requires water systems to inform consumers about the contents of their drinking water, and everyone would be receiving this report at their residence. Fluoride supplementation is very important in the absence of fluoridated water. So again, those recommendations have been decreased in 1994 to avoid the risk of fluorosis, because some children have been getting fluoride, ingesting fluoride through various sources, such as juice that's been reconstituted in different states that do have fluoride. So the recommendations make it extremely safe to give the fluoride supplements and have the optimal effect of protecting the teeth. So again, there's a couple of ways you could supplement in the absence of water fluoridation. One is to consult the recommendations and, for example, give a 2-year-old child 0.25 milligrams of fluoride if they live in an area that has less than 0.3 parts per million of fluoride in the water, or alternatively, you could recommend that they drink fluoridated water, and an 8-ounce bottle of water would contain 0.2 milligrams of fluoride ion, which is approximately what they would need to take based on the recommendation. So again, this has 2 factors, 2 variables. One is the age of the child, and 2 is the amount of fluoride contained in the water. So the other source of fluoride, excellent source of fluoride, is fluoridated toothpaste, and studies have consistently shown that brushing with fluoride toothpaste for 2 minutes a day, twice a day, would significantly decrease caries rates. That's why it's important to tell patients to use fluoride toothpaste on a regular basis. So for children less than 3 years old, we recommend a small amount of toothpaste. This is regular toothpaste, the amount of a grain of rice. For children 3 and older, we recommend a pea-sized amount of toothpaste, which would be the most effective way to reduce caries rates. Professionally applied fluorides, including Fluoride Varnish, again, very simple to use and implement, very inexpensive. I think it's once people get used to it, they realize that it's an easy way to have to make a significant impact. So basically, you just need some gloves, fluoride varnish, which gets painted on the tooth. It's a yellow, sticky. I tell the patients it's usually sticky like honey, and there's different flavors. We get usually the bubblegum flavor, and you paint it right on the teeth. You give the patient some post-op instructions, including not eating, drinking for half an hour, and it's very effective in reducing caries rates. Like I mentioned, our medical providers have increasingly started applying fluoride varnish on children that do not see the dentist on a regular basis, and that's a great way to intervene and prevent and control caries in those patients, especially in areas where there's no access to dental care whatsoever. So the ADA recommendations say that for high-risk patients, you should apply fluoride varnish 2 to 4 times a year. Low-risk patients may not benefit from it as much, but across all ages, if you could get the patients in 2 to 4 times a year, you will see a significant decrease in caries rates. And this is important for our patient populations, typically don't seek dental care routinely. That's why, like I mentioned, we use a van wherever possible, and we use portable equipment to go out into the community, get to the children, apply the fluoride varnish on a regular basis. So the next concept is that caries is an entirely preventable disease. So beginning early, interrupting the caries process by removing the bacteria, neutralizing the acids, doing all these things, intervening early on is going to help significantly reduce the caries rates. That's why we feel like by partnering with different agencies, including those providing care to pregnant moms, we are able to talk to them early about the importance of oral health, taking care of their teeth, to decrease the risk of vertical transmission of bacteria to their children. Sealants fluoride, again, the NIH has long known that using sealants and fluoride on a regular basis can almost prevent oral decay. The sealants fit right into the grooves of the teeth and prevent decay into the occlusal surfaces, right into the pits and fissures of the tooth, whereas fluoride varnish is excellent in preventing decay on smooth surfaces of the teeth, and it's easy to apply. You could, we do a lot of health fairs where the patient just stands, opens up their mouth, and we apply the fluoride varnish. The last concept is that dental home is extremely important, establishing a dental home by age 1. The AAP recommends that infants should have a dental home at the time of their first tooth erupting. The AAP policy statement recommends that mothers, caregivers receive an oral health assessment, that practitioners assess oral health risk in infants and children, recognize the signs and symptoms of dental caries, and make timely referrals to a dental home, also providing proper instructions on brushing and flossing and nutrition, and providing timely referrals and assessing the child's exposure to fluoride and administering fluoride accordingly. So determining risk is basically dependent on evaluating risk factors that cause mineralization of the tooth and protective factors that cause remineralization of the teeth. The ADA has its own guidelines for dentists, and again, it lists some of the risk factors, such as high titers of cariogenic bacteria, poor oral hygiene, prolonged bottle or breastfeeding, eating disorders. So it lists a number of different risk factors, and its risk, according to the ADA, is dependent on having one or multiple risk factors and having caries lesion present in the mouth. So caries risk assessment is really the cornerstone of disease prevention and disease management. It's used to determine and understand the patient's risk for developing new caries or recurrent caries, and it involves a patient or a parent interview, clinical examination to determine the risk level, and allows for a customized preventive treatment plan to be developed. The ADA has its own form, again, based on its criteria. For billing purposes, they define high, medium, and low risk, and there's specific a 3-year period, but it's important to evaluate all the different tools that are out there for assessing risk and seeing what works best for you in your practice. So there are 3 domains to be explored and documented in risk assessments. One is the risk or biological risk factors. This includes things that we discussed, such as frequency of snacking, type of food, continual bottle use, medication. Protective factors is the other thing to be considered. Fluoride from all sources, xylitol, and does the patient have dental home, and some clinical findings. There could be disease indicators such as white spot lesions, the presence of a lot of plaque, or the lack of saliva. So on the right-hand side here, you see the AAP caries assessment form, and it takes into account the primary caregiver's decay within the past year, whether the child goes to sleep with a bottle, whether they have a dental home, whether they have exposure to fluoride varnish, again, white spot lesions, plaque, and obvious decay. So in the absence of salivary markers, which can be used to test the amount of bacteria present in the oral environment, in the absence of those markers, which could be expensive to use and implement in community health center settings, there are 3 findings that are always associated with high caries risk, and they would be prior caries in the 12 prior months, 2 having new caries lesions in the caregiver's mouth in the past 12 months, or 3 having white spot lesions, decalcifications, or other clinical findings that put the patient at high risk. So, what we have done at our center is develop our own risk assessment tool, keeping in mind that if the patient has any of these 3 findings, they're automatically a high-risk patient. Other factors that increase patients' risk for caries, this is typically more applicable for adults, is prescription medication. A lot of the medications currently in use cause dry mouth. About 500 plus medication, more than 80% of commonly prescribed medications cause dry mouth, and using multiple medications significantly increases your risk for dry mouth. Again, more applicable for adults, tobacco and alcohol. Alcohol dries your mouth and decreases saliva flow, and tobacco as well has, especially chew tobacco, has abrasives and sweeteners, to counteract the bitterness of the chew tobacco, and once it's left right up against the teeth, it significantly increases the risk for caries. So some of the protective factors, again, we talked about saliva and fluoride. Xylitol is another protective factor if the patient is using xylitol regularly, antimicrobial agents and mineralization agents, which we will discuss a little bit more. So other than fluoride, which again in low concentrations, like the concentrations found in water, other than fluoride, which also again promotes remineralization, inhibits mineralization, there's paste such as amide paste, which contain calcium and phosphate, and these pastes can be given to patients to use on a daily basis, and these will help increase the amount of bioavailable calcium and phosphate in the mouth for remineralization. There's other agents such as Remin-Pro, which contains nanohydroxyapatite crystals, as well as fluoride, which helps also remineralize the tooth. Other protective factors, if the patient is using an antiseptic such as chlorhexidine, which is often prescribed by and then also, once again, fluoride is an antimicrobial at higher concentrations. So what you have in your toothpaste and in a school-based rinse program is going to be bacteriostatic or bactericidal, as well as remineralization and a remineralization agent that inhibits mineralization. Protective factors, again, xylitol is a 5-carbon sugar. It does not get converted into lactic acid. The bacteria does not have the capability to ferment it, and there's no production of glucans to adhere the bacteria together in plaque. Xylitol also stimulates saliva flow and changes in the oral environment for the better. In high concentrations, there's some side effects, including diarrhea, but these have been only reported in extremely high doses. So in addition to evaluating risk factors and protective factors, we look at disease indicators. So part of doing a risk assessment involves looking in the mouth to see if there's plaque or other signs and symptoms of active disease, and one of the major ones is the white spot lesions that we mentioned. So when you look at a tooth, especially around the gum line, you might see white spot lesions, and that's where you know that there would be some active demineralization happening, and these lesions can be remineralized with use of fluoride varnish, and again, for high-risk patients, bringing them in every 3 months would help tremendously. Other clinical factors that we would look at, especially in the dental office, is if the patient has any enamel defects, defective restorations, the patient is undergoing orthodontic treatment, there's going to be more likely plaque accumulations around those, around their teeth. So in order to communicate risk, we have developed at our center our own form based on reviewing other forms and looking at the criteria for risk assessments. And our form basically has a risk assessment portion on top. We record the risk level, and then we work with the patient to give them some self-management goal to work on one specific goal to improve their oral health. We give them the form as well as a kit to take home. Our kits for children include brushes for the parents, the siblings, they have siblings, so that we emphasize the fact that this is a transmittable disease, that we want to have the parents control their oral health to decrease the child's risk. We also have sippy cup for children that are, for young children less than age 2, to help them start using sippy cup, transition from baby bottle to a sippy cup. And for older children, we'll have the toothpaste and brushes for the parents, like I mentioned. We've also developed a tool for our Ryan White patients. It looks a little bit different than the risk assessment for children, because we're looking at more things that apply to adults, such as smoking, use of drugs and alcohol, and other dietary habits. And we created a self-management goal sheet that goes along with that risk assessment form. So in their case, they take home the self-management goal sheet, and we just the information from the risk assessment. So again, the way we try to do it is focus on one goal for the patient. So if they come in, we try to assess some of the risk factors. Somebody who is seen in medical, who does not have a dental home, is going to be encouraged to make an appointment by their first by age 1. Caregivers are going to be encouraged to make appointments for themselves as well. Patients who drink a lot of juice or milk at bedtime are going to be encouraged to switch to tap water, using fluoridated water, or drinking juice and other sugary beverages with meals to prevent or decrease their the damage. Patients who snack frequently on sugar and other high carbohydrate foods are going to be encouraged to switch to proteins, healthy snacks like nuts, cheese, or chewed gum to stimulate saliva flow. It is very important, again, to brush for 2 minutes twice a day. So oral hygiene could be one of the self-management goals for somebody who's not brushing. We typically focus on only using one self-management goal. If a patient comes in, they're not doing anything that we want them to. We try to encourage them to pick one self-management goal, go home, work on it, and if we have that, one small victory, then we build on it to encourage them to continue to improve their oral health. So in terms of billing, the codes that we use in medical are a little bit different than the ones in dental. So for doing an oral health risk assessment in our medical center, the ICD-10 diagnostic code is Z01.20. The billing code is 99420. Fluoride Varnish application have a different diagnostic and billing code. Okay, I think that's, I'm a little bit early. I talk fast, so I'll see if there's any questions.
Thank you, Dr. Joaquin, for this wonderful presentation. We're going to start the Q&A session. So if you have any questions and if you'd like to ask Dr. Joaquim a question, please submit it through your question box on your control panel. Or if you dial in through your phone and would like to verbally ask Dr. Joaquim a question, use the raise hand icon on your control panel, and your line will be unmuted. While we wait for some questions, I'd like to remind the audience to please complete the post survey. Your answers help us to improve our webinars. Just to break the ice, Dr. Joaquim, and this is a question that I have for you. You mentioned the streptococci as the carcinogenic bacteria. Is that the only one, or is there any association of any other bacteria in the mouth that can produce tooth decay or caries?
There's other bacteria, but the main culprits are streptococci and lactobacilli. But there's some research showing other bacteria involved in the process as well. Not to the extent that lactobacilli and strep are involved.
So we have some questions here.
All right.
So the first question is, so if kids and adults do consume fruit juice, what's the best way to prevent the causes of cavity?
Well, again, what we would recommend to the patients is to consume them with, with meals. So what's harmful is the repeated, frequent exposures. So if you're drinking juice, certainly there's some benefits from some of the vitamins that might be contained. But if you're drinking them with your meal, there's going to be less of a harmful effect than there would be if you had your meal, then an hour later or 20 minutes later drank juice. So if you're sipping basically juice all day, there's going to be more of a concern for us in getting cavities than if you just consume your beverage with your meal.
Great. The next question we have is, can you discuss the difference between systemic intake of fluoride and topical fluoride?
Yeah, so the systemic fluoride is really what you would get from fluoridated water and or ingesting a supplement, a fluoride supplement. The best effects, the best preventive use of fluoride is through topical fluoride. So if you're drinking water, that's, you're going to get more bang for the buck if the fluoridated water is sitting on the teeth, because then it's going to again inhibit mineralization, promote mineralization of the teeth. Toothpaste, like I mentioned, is a good way to apply topical fluoride. Systemic fluoride is good only when the teeth are forming, but again, you have to be very careful about the amount that you're using. So if you're going above the recommendation, you kind of risk having the child have fluorosis. But the recommendations are very good in avoiding that. So if you're sticking to the recommendations, you're going to be in pretty good shape. There's very little risk, like virtually no risk of fluorosis that way. After age 8, we don't worry so much about fluorosis because most of the patients' adult teeth have formed, the crowns have formed. So the more fluoride, the better, because we're just going to get the net benefit of using fluoride, whether it's ingested or topical. But again, topical is the preferred mode of fluoride and gives us the most bang for the buck.
Great. All right. Our next question is, one of the slides mentioned possible tumors after exposure to high concentrations of xylitol. Is there any data on that?
I think that's very little data, and again, with extremely high concentrations of xylitol. I think there's still more studies that need to be done to look at xylitol, but certainly in the small concentrations that you would find in gum or any other products, you're not gonna you're not gonna have a concern for tumors or anything like that.
And then the last question we have is someone asking you to show the CPT code again for fluoride varnish.
Okay.
I can change the presenter back to you.
Let me see if I could find it. I'll read it for you.
Okay.
So the code that we use for risk assessments, just kind of assessing the risk, and again, that's what I would recommend that anybody who hasn't done this, who wants to start implementing more oral health access to their patients, is to start by doing risk assessments, figuring out what form you like. Do you want to use one of the existing forms, the AAP form, the ADA form? Do you want to develop your own? And then test that, become more comfortable with it, and then then move on to varnish, because everything else builds on identifying who's high risk and who's not. So you have to decide on the tool that's going to help you decide, determine who's high risk. So the ICD-10 code for the risk assessment that we are using is Z01.20. Again, that's Z as in zebra, 01.20, and the billing code is 99420. And then for fluoride varnish application, it is Z41.8, and the billing code is 99429.
All right, and then we've just got one more. That's how would you suggest addressing / educating caretakers who are bringing children into the clinic with caries, who also have caries themselves as a transmission of bacteria from parent to child?
Again, that's one of the goals that we have. So in our center, we have a self-management goal sheet. So we would typically tell the parent, is it okay if we discuss with you some of the things that would help improve your child's health? These are the things that we typically discuss with other patients. We'll review the self-management goal sheet. We'll tell them about the benefits of each thing, whether it's brushing on a regular basis, using fluoride, establishing a dental home by age 1, or taking care of themselves. If they if they're receptive, we encourage them to make an appointment. We make their appointment on the spot, and otherwise we just we try to kind of see what they're most open to and have the small victory, have them do something. If they're not doing anything, we want to just take steps forward. We're not going to fight or argue for one specific change. If there's room for different improvements that they could do, we'll just pick one that's going to be easy and doable, and we'll work on it with them.
Great. And that is all the questions we have.
Great. Thank you so much.
Thank you, Brendan, and thank you, Dr. Joaquin, for this excellent presentation. To all attendees, please visit our website at www.nchph.org. You can find recorded webinars, monographs, fact sheets, training manuals, newsletters, and information on our regional and national symposiums. Also, information on our one-on-one training and technical assistance. You can also join our mailing list and receive HRSA and Medicare updates, funding opportunity announcements, information on senior programs, and other resources and services that the National Center for Health and Public Housing provide to health center grantees. You can also follow us on Twitter, or you can subscribe to our YouTube channel. If you have
our website, nchph.org, will be where you can find a downloadable copy of the slides from today's webinar.
Thank you, Brendan. And if you have any training or technical assistance need, please contact any of our staff members. We'll be happy to assist you. One more time, I'd like to thank Dr. Joaquin for this wonderful presentation. All of the attendees, thank you very much for attending this webinar, and have a great afternoon.